first speakers. We've got 4 speakers at 20 minutes each. They'll take the call about whether they're open for questions or not. Our first speaker are Grant, Sara and Patrick Gould. Grant Sara is the Director of Inform and has a fantastic track record at bringing data together, changing clinicians' behaviour and then publishing that data. And he's also presenting with Patrick Gould from Mind Garden and with working with Grant as well. So let's please all welcome Grant.
Thank you. Thanks very much. And you know, Patrick's, I acknowledge Patrick as my co-author, but he's abandoned me to do the presentation alone up here. So I'll
it's not on that computer. It's confusing.
It's not on that computer.
So if you advance with slides, it's on this computer.
Okay. Oh, I see what you mean. So.
Your presentation. Sorry, what's up on that screen?
Yep. So.
You need to use the clicker to make it move. Yes.
There's just far too much technology for an old baby boomer here.
My apologies.
So.
Just this one here.
Yep. It's not doing it.
Apologies for that live stream. Last year we had about 1,900.
There we go.
200 or 300 international as well, so live streaming and recording. So hence it's a little bit more technology we have to wrestle with.
So I'll trust the technology and try and keep going. But just to start by acknowledging that we're meeting on Gadigal land and also the Camaragal people and the Gayamagal people on whose lands I work and live. Is that any better? I think the microphone's not for the room, is it?
Yeah,
it's
no,
for
it's for both.
It's for both.
I'll increase the
Okay.
volume.
And just also to acknowledge that we're looking at data from many thousands of people who've used New South Wales mental health services, and we do so with gratitude and respect. So, just obviously the last few years have been a reminder that vaccine-preventable illnesses remain a really important cause of illness and of death. We did some work a few years back where we looked at overall preventable hospitalisations in New South Wales mental health, in New South Wales health services, and we really found, that one of the notable findings in that was surprisingly high rates of vaccine-preventable illness amongst the other illnesses that we were looking at, and so that prompted us to do further study. Apologies, so I'll stop looking at this screen here because it's completely wrong. So if I go back, okay. So we wanted to do a study to look at focusing in on vaccine-preventable illness and to ask the question about what's the rate of vaccine-preventable illness in people who use mental health services in New South Wales. And not just to get the headline rate, but to try and focus in on the detail, to get a sense of how that differs for different groups of people and for different types of vaccine-preventable conditions and across the state. So the work is part of the Mental Health Living Longer project, which is a data linkage that New South Wales Health it does, and that we are running to try and broadly look at understanding the interface between physical health and mental health problems and to help drive service improvement and policy change in New South Wales to help improve those issues. And in this data set, we're looking primarily at hospitalisation data and at our community data as well. The linkage has data on people from across the New South Wales population, not just people who use mental health services, so we can compare rates and pathways and outcomes. And so what we did in this work was we looked at all vaccine-preventable hospitalisations in New South Wales. And I'm just going to fast forward because there's no way I can read the numbers from this side of the room over there. We looked at, next, are you clicking that for me? Sorry, thanks. And we identified about 95,000 vaccine-preventable hospitalisations. Now, when we're talking about vaccine-preventable hospitalisations, this is what we're talking about. So admissions to a hospital with any of those 19 or so conditions listed there, broadly in 3 groups: hepatitis B, respiratory infections, including influenza and COVID, and a range of other things. The conditions listed in bold there really make up about 95 to 98% of that group. So they're really the major ones. Thankfully, a lot of those other ones are rare, at least as causes of hospitalisation. Then we, yeah, thank you. So then we calculated rates of admission per 100,000 per year and looked at comparing the rate in people who had use of our mental health services to the rest of the New South Wales population. So in this study, the mental health cohort are people either who've had contact with our public community mental health services or who've had a public or private hospital admission for a mental health care in the study period. So that's about 418,000 people in the mental health cohort. And then we compared the rate ratios, adjusting for age and sex and disadvantage. And here's broadly what we found. So in these slides, the blue is the rest of the New South Wales population. The orange bars are the rate in our mental health service users. And you can see on the left, you've got any vaccine-preventable hospitalisation. Then you've got those three main groups, respiratory, hepatitis, and other. And you can see that the other group is quite a small group. It's mainly shingles, and it makes up quite a small percentage. So just focusing on the other two groups, respiratory infections, flu and COVID, and some pneumonias, and hepatitis, roughly equal in volume. And you can see you don't need a complicated statistical analysis to see that the rates are much higher in the mental health service users in the orange bars. If we just do the crude rates, the crude comparison dividing one by the other, you get the light grey bars down there, so about a nearly threefold difference. But of course, mental health consumers are younger than the New South Wales population on average. And so once you adjust for age and other differences, the adjusted rate ratio is 3.2-fold. So 3.2 times more likely to have vaccine-preventable hospitalisations compared to other New South Wales residents. You can see it's present across all of those grey bars, so it's present in all of the groups, in respiratory infections, particularly high in hepatitis. But when we looked at all the individual diagnoses as well, the individual conditions, pneumococcal pneumonia and so on, it really was increased across the board to roughly equivalent degree. So focusing further, one finding that's, I think, not commented on a lot in a lot of this kind of epi research, but is a consistent finding in a lot of our data, is it's not just about higher rates, but it's about younger age. It's about earlier onset of a range of conditions. And so we found that particularly the risks were high in mental health service users in their 30s, 40s and 50s. So what you're seeing here is the average age at admission. The orange dot is the average age in mental health service users, the blue in the rest of the population. And you can see, with almost no exceptions, that mental health service users were much younger when admitted. So the average was about 9 years younger, and particularly younger for respiratory infections, so between 9 and 13 years younger at admission. Another way of looking at that is this, where we're comparing the rates in individual age groups. So you can see here, you've got males on top, females on the bottom, population in blue on the left, mental health service users on the right. And you've got the rate in each of those age and gender groups. And you can see that if you look at the blue side, mostly vaccine-preventable hospitalisations are relatively uncommon in people under 50 or 60, and then increase steeply later in life, particularly in the 70s and 80s. And a lot of that is about influenza. If you look at the orange side, you can see those graphs bulge in a different way, and particularly in people in their 30s, 40s, 50s, and that's reflected in the rate ratios for each individual cohort, which are the grey bars on the very far left. So particularly for men aged 35 to 65, they were about sixfold more likely to have vaccine-preventable hospitalisations, and women in their 40s and 50s about fourfold. So beneath those rates, there really is significant impact for the people involved, for their families, for the health system. And just showing you those rates kind of understates that slightly, because there's a kind of compounding effect here. So we found that the chances of an individual having at least one vaccine-preventable hospitalisation in a mental health cohort was 6%. So people had a 6% chance of having at least one admission in the study period, compared to 1.5% for the rest of the population. But mental health service users were more likely to have more than one, so they had an average of 1.7 admissions per person, and when they're admitted, they stayed longer as well, staying 8.2 days rather than 7 days. And so the kind of cumulative effect of that for those people was that in this, the way this is defined here, that the mental health service users made up about 3% of the population, but they experienced 12% of the vaccine-preventable hospitalisations and about 13% of the vaccine-preventable bed days. The other thing that we're trying to do with this data is develop detailed local data to help kind of prompt and guide and support change efforts by local health districts. And so this is showing you the rates for local health districts. Each one of the rows here is one local health district. I haven't identified them here, but we report it back to them in an identified way. And the blue dot is the rate in the population. So you can see there's a quite a variation across New South Wales, more than a twofold variation in the vaccine-preventable hospitalisations at the population level. And it's mainly the metropolitan areas, particularly the inner city areas towards the top, and the rural and remote areas towards the bottom. So higher rates in the city. If we look at our mental health consumers as the orange dot, and that grey bar is the gap in between the two, and you can see that across the state there is a gap in all LHDs, and even though in absolute numbers there's much lower rates in mental health service users in some of those rural LHDs, proportionate to their population rates, it's still a very substantial gap. That gap varied from about 2.5-fold to nearly 4-fold. And so, this is trying to provide the data to services in a way that they can make use of, and we'll talk more about that on Thursday. So just to finish up quickly, then it is important, I think, in looking at this data to recognise that there's just not a simple linear relationship between vaccination and vaccine-preventable hospitalisations. That the answer to this isn't, if only everyone was vaccinated, that would, close that gap. There's likely to be many interacting factors, and we've learned, a lot more about that collectively through COVID. And of course, those factors are likely to be different for different people, different conditions, and different places. But it's quite likely that some of those factors will include potentially the mental health service users in some settings might be more exposed to vaccine-preventable illnesses. They might have lower vaccination rates. They might, despite being vaccinated, be more likely to become ill. There is some evidence of less effective vaccination related to a range of mental and stress-related factors. There's also likely to be an impact of other conditions on severity of illness, and that's certainly, we know that's been a big factor in COVID. People who have comorbidities, who have respiratory conditions or heart conditions, much more likely to get more severe illness and need hospitalisation. And also, it's not just severity of illness that drives hospitalisation. It's your resources, it's your supports, it's your living situation. And so there might be an interaction across all of those fields. Understanding how those interact and how they interact differently in different groups is clearly important to try and help prevent some of this. And certainly there's more work that we're seeking to do, and Patrick is in the process of doing to further explore some of this. So, and particularly with that, in the current linkage that we're about to do, we're adding in data on vaccination rates through the Australian Immunisation Register and the Notifiable Conditions Information Monitoring System to look at rates of those conditions, influenza and COVID in particular. So we can try and tease out some of those interactions and how those things combine. There's clearly a need to identify and support models which support access to vaccination, and Patrick will be talking a bit later, unfortunately in another room, on some models that South East Sydney have been implementing to do exactly that. There's probably also things we can do at the policy level. There's clearly some policy barriers and financial barriers, and to being able to access vaccines. So the data could be hopefully a prompt for change. And as I've mentioned, we're trying to develop local reporting to help support and prompt action by local health districts. So really, I'll stop there. I just wanted to acknowledge and thank the collaborators and people involved in the Mental Health Living Longer project. I've listed some of the names there, but particularly to acknowledge and thank Fred and Jen from our team, and Wendy, who's not here in the room with us, and Patrick, who've been involved in helping them work and do this work. So thank you very much, and I'm happy to take questions if time allows.
Yeah, we've got time for one question from first in.
John,
Right, thanks very much for the work. Is there any comparable work for different other compromised groups like social disadvantage or homeless people or compare in this?
Look, it's a very good question. I'm looking back towards you there, Patrick, to see if you might know any. I can't think of anything. I know certainly in some of the other kind of primary and preventative work, for example, cancer screening, there's good work to that. And what we see is that the gaps in mental health service users are actually even greater than the gaps in Aboriginal people or in women from culturally linguistically diverse backgrounds in, for example, cervical screening. So I suspect if we had comparable data, it would tell us a pretty sad story. Yeah. But I don't know if anyone else knows if there is comparable data. Thanks, Patrick. Fantastic.
Actually, I failed as a chair. I've actually got a few more minutes, so there's time for another question or so.
Okay.
My only job is to start and finish on time, and you're so great, Grant, so much you detail so quickly. But any other?
Do you understand that you don't know the vaccination rates in that population?
That's right. In this data set, we don't. All we know is the hospitalisation. So the next linkage will include the vaccination, so we can look at that.
I've got a question.
Yes.
I mean, one of the exciting things about the work you do is the engagement with service directors, etc. Tell me how about that interaction, how they're responding to the data, in terms of changes in practice, and maybe how the branch is responding in terms of changes in KPIs.
Yeah. Look, I think in general, people love to see data, and I think it's one of the reasons it's a useful kind of lever and tool for change. So certainly, I mean, to me, there's two groups that have been very engaged with this data. So certainly the local health district clinical leaders have been very interested. A number of local health districts have been engaged with trying to implement improvement efforts. The other group that have been very interested and engaged has been the policymakers. So New South Wales Health is currently doing some work to update its overall vaccination plan, and certainly the population health, public health colleagues have been really interested in this and used it to kind of prioritise and really identify mental health as a priority issue and cohort within the overall vaccination strategy. So yeah, I think there's an appetite for the data.
One more question.
Has there been a response, a practical response with that particular data?
Yeah, definitely there are individual projects and improvement projects happening in a number of LHDs, and there has been an inclusion of a commitment to trying to support this within New South Wales policy. I think there's more we could do, and certainly, for example, at the national level, through the college or otherwise, some of the financial barriers to subsidised vaccination for flu, for shingles, for various things, and is another area we could kind of think to try and use this data to push a little bit more on.
Okay, well, I just, once again, you'll have an opportunity to see a lot more of Grant's work through the conference, and you see that the quality of that it's just astounding to me, like the quality of the data linkage, the links to health services, quality improvement, and also the international publications and impact that's having. It's really world leading. So, and I think the other thing that you pointed out was around the age of onset as well, with some really new insights. So I'd like us all to join and thank Grant.
Thanks, Ross.